Welcome everyone. I'm Mohammed Al-Awami from Saudi Arabia, and it's a great pleasure to host this episode of the Gulf Intervention Society here in Dubai. And our topic today, this is a roundtable discussion, and our topic today is about calcium modification in complex coronary intervention. Joining me here is a distinguished colleague, Professor Mohammed Egrid, the director of the CHIP CTO program from the Freeman's Hospital, Newcastle, United Kingdom. Thank you so much, Professor Egrid, for joining us. And it's a great pleasure having you here in Dubai, and we'll be discussing about complex coronary interventions, about calcium modifications. Professor Egrid, we know that calcium remains a great challenge, one of the most important challenges in modern PCI. Not only it affects lesion preparation, stent expansion, and long-term outcome, but notoriously it carries a high complications risk. First of all, I would like to talk about the devices used in calcium modification. Now, we do have, like, for example, atherectomy versus balloon-based devices. With the newer generation now, we could see that the rates of atherectomy devices used are falling with the balloon-based therapies, basically. Where do you see the landscape going and the training of the newer generation of interventionists going in that path?
Well, thank you very much for the nice introduction, and it is really a great subject, a very important one, because you're absolutely correct. We know that calcium is prevalent. If you look at angiogram, between 30 to 40% of cases, if you do intravascular imaging, up to 80%, and this is well documented. So knowing how to deal with calcium is very crucial and very important, because it doesn't only affect the acute performance of your angioplasty, but also the long-term outcome, as you mentioned. And it has an impact on how you deal with each patient on their own. And of course, with the aging population, with the prevalence of comorbidity, and people are living longer, lots of diseases, previous intervention, etc. So this is a really crucial, important subject to be able to handle it. And of course, you're correct. Nowadays, there's a shift toward more balloon-based, particularly with the introduction of the IVL or lithotripsy, which is a fantastic addition to our armamentarium. But of course, it does not treat everything. So the atherectomy devices remain a crucial part of what we do. And again, it's very correct that you need to be really adept and well trained to use these devices, because if you're not and you try to use them, there's always a possibility of complication and problem. And that's where the importance of continuing to use these devices on a regular basis. Of course, now we use intravascular imaging, whether it's IVUS or OCT, to assess the calcium, length, depth, and circularity, etc., to be able to decide what to do. Rotablation and orbital atherectomy are crucial part in what we do. And I always said, even from the start, if you are going to do rotablation, the problem with what used to happen in the beginning, that people will leave using rotablation to the most difficult case. They don't use it frequently. So when it comes to the difficult case, trying to use rotablation, everybody's stressed, everybody's finding it difficult. You have to use it on a regular basis to be able to maintain this skill and then be able to manage it very well. And this is where, for the new generation, really, lithotripsy IVL balloon, despite its prevalence, it is not going to be enough for every case. So this skill has to be acquired and has to be maintained by trying to do this regularly, and also maintaining at least minimum probably 30 cases to 40 cases a year, and this is really important. The reason why IVL has become prevalent, of course, it's a balloon. We use it on a regular basis. This is what we do. So it's much easier to be used, even without much experience, and it's very safe and very efficient. And I think it's a great addition, but that does not substitute the orbital and the rotablation atherectomy devices. And laser, of course.
Of course. I remember hearing it from you personally, that most complications that come from atherectomy is skill-related. I would like you to elaborate more on that. Like, can you give some tips and tricks basically to avoid these complications that are skill-related?
Yeah, I mean, of course, it is. I always, when you're treating, of course, knowing the mechanism of how the rotablation or the orbital atherectomy work is important. We know that it works by differential cutting and by rotational advancement. And the analogy I use is like when people are using a blade to shave their beard or legs or whatever it is. If you're doing it properly, you could shave your beard and legs without any issues. Any little glitch or any little deviation, you cut your skin. This is very similar to rotablation and orbital atherectomy.
Yeah.
you could do it without any issue, but if you try to step away from what needs to happen, that's when the problems happen, like burr entrapment or deceleration or dissection, etc. So following, and no device comes on the market without being tested rigorously, and the steps that needs to be taken are very important. So this is why you need to stick with it. The problem with mechanical things we do and procedures, sometimes people do something and it works, and they start doing it again. They get away with it once, twice, three times, but at the fourth time something's going to happen. So it's really important to make sure you follow the steps. You do it in the how it's supposed to be done, so you don't run into trouble. Doesn't mean you're going to eliminate complication at all. Any mechanical intervention will have some complication, but following the steps and paying attention to details and doing the little steps correctly will lead to getting the outcome very well, and the larger steps important,
of course,
and reduce the chances of complication enormously.
Yeah. Now, when we think about balloon-based devices, lately we had two trials, non-inferiority trials, comparing ultra-high pressure balloons versus IVL and cutting balloons versus IVL, and both were basically non-inferior. How do you see that changing our perception to IVL in the future?
It's a very interesting question, very interesting two studies. I'm waiting to see the whole study publication to see how that was conducted. The non-inferiority, always there's the set or where you set the non-inferiority level and how you conduct it, and then you start kind of chasing shadows and it becomes more and more. It's very good news because we know IVL might be more expensive and there is a lot of economic restraints in multiple areas of the world. So if the high pressure balloon or the cutting balloon works the same, which appears to be, but I think we know the bulkiness of these balloons, the effect is not always the same. It's very good news. I think this needs to be replicated in real life to be able to say, oh yeah, this is how it's worked, and in bigger studies. But so far the signals are good and very encouraging that you could use these balloons instead of the IVL, which is a bit more expensive.
You mentioned about like intravascular imaging, the use of intravascular imaging in complex. We know now this is endorsed by guidelines and we're using it more and more in calcium-based therapy, basically. Yeah. But can you just tell us from your experience, when is it more useful and are we using it enough?
So in the old days, there used to be something called the Washington test, which you try to put you put the wire, you try to put the IVUS down. If the IVUS doesn't go, you know that you need debulking. Nice. And this remains the same. Of course, we're talking about two different IVUSs here, or OCT. The Eagle Eye, which is a little bit more bulky, 3.2 French, versus the Avigo or the Boston or the Refinity from Philips. So if the IVUS doesn't go, you know that you need debulking. So ideally, if you could pass the IVUS, that would give you an idea, as I mentioned at the beginning, about the depth of the calcium, the thickness, and maybe IVUS doesn't tell you the thickness, but OCT. Then you could decide which device you're going to use. Orbital atherectomy or rotablation or IVL all work in a different mechanisms, obviously, and they all could be very effective depending on what you're treating. So intravascular imaging, if you could do it before, fantastic. It's always very helpful. But often with calcium, and I always say, if you think you need debulking, go ahead and do it. Don't have what we call the rota regret or the debulking regret. Yeah. You think you're going to get away with it. This is and this is what keeps your also skills up, always running. So you try to do it with a balloon. You use a balloon once, twice, and sometimes multiple balloons and guideliners, where really if you use the debulking from the start, you shorten your procedure time, you prepare the vessel much better. Yeah. And once you've done that, then you could IVUS again and assess the response of the calcium. And then when you do the stenting, so IVUS uses pre, during, and post is very important to know why and how. And this is where intravascular imaging are crucial in these cases.
I see. And would intravascular imaging help you in terms of deciding when to use a hybrid technique, like RotaShock, for example? Or is it worth the investment? Like, we spend a lot.
Yeah, I mean, there's a lot nowadays where combination of the two mechanisms are happening. Of course, the intravascular imaging will allow you to decide whether it's luminal or really deep calcium. We know if you have deep calcium, debulking is not going to help. So if you see that there's no point of trying to use orbital atherectomy or rotablation, you go for IVL because deep effect. And of course now we have the Lethix balloon, which is a mechanical IVL by applying very pointy pressure in those little nubbin on the balloon. So yes, ultrasound could help you with this. Nodular calcium remains our most difficult case to treat.
I agree.
I always think nowadays, this is from clinical experience, orbital atherectomy is probably very good because it could give you the bigger kind of orbit that will allow you to treat the eccentric and the nodular calcium. But nonetheless, rotablation can still be used. IVL, the data tells us it works. In real life, I think it's a 50-50, and it's not always, at least from my experience. So, and I hear that from a lot of colleagues. So yes, ultrasound does help you to kind of to decide what to. But again, we have to. One thing's always kind of a concern, or there's a lot of expenditure on treating calcium, as you said, using orbital atherectomy and shock wave, or rotablation and shock wave. And so I despair sometimes when I see people using rotablation 1.25 burr in a 4O vessel. If you are going to use rotablation, you have to size correctly, you have to do the rotablation correctly. So taking a 1.25 burr up in a 4O vessel and saying, oh, the art is still not being prepared and the balloon's not expanding, it's not because it's not enough. You need to size it 0.7, 0.8. I still think rotablation is a fantastic equipment to be able to deal with calcium, but do it more. Of course, the argument is whether you debulk or whether you modify. Debulking can be very important in many cases, modifying in others. But yes, so there are some, probably 1 to 2% of cases where you may need to use a combination, but not very rarely. So I always advocate to do the upsize your burr to be able to achieve more rather than do anything else. But IVUS or intravascular images sometimes can tell us, yeah, we need IVL because it's deep and the rotablation hasn't done enough. So it's kind of a kind of building your experience and continuing to do these, particularly the orbital atherectomy and the rotablation, the debulking device, to keep the skill going so you don't run into difficulty when you try to use them. If you leave them for a long time, they come to use them in the most difficult cases.
Of course. I'll come back to nodular calcium because I've got some particular interest in that, and I call it basically that it's our worst enemy, basically. But before that, I would like to ask you more about excimer laser, and you're an expert in that field. Just for most of us who are not exposed yet to excimer laser because of the lack of equipment, lack of this facility basically to use excimer laser in most centers, like, where do you see it? Where, like, do you see excimer laser fit in that spectrum of calcium modification?
I think laser is really a very effective and very important tool. If you have it, it will help you in many, many cases. The commonest indication for laser, most effective, is uncrossable and dilatable lesion in in-stent restenosis, in thrombus, in under-expanded stent, and of course in calcium. In heavy calcium, I have to say laser might not be my first approach, but in many cases where I was, as you know, rotablation or orbital atherectomy require a special wire. So if the wire doesn't go, no rotablation wire, no orbital atherectomy wire, no rotablation, no orbital atherectomy. Laser can work on any angioplasty wire,
of course,
and that's where it becomes very important. And could work even if you have more than one wire. On a bifurcation, you leave the wire in the bifurcation, or if a body wire, it works, no issue here, none whatsoever.
Great.
And of course, the recommendation for laser has always been to use it with saline. Nowadays, we know that we could use contrast. If you use contrast, it forms cavitation bubbles that can increase the pressure in the arteries up to 120 atmospheres in comparison to 50 atmospheres, for instance, with IVL. And that's very effective and can allow you to modify the lesion dramatically and achieve a very good outcome. We have just submitted our consensus, international consensus, to place laser really up front. The problem with laser over the years has always been that people leave it as a last resort because it's not available all the time, not too much experience with it. So people try and non-compliant balloon, high pressure balloon, rotablation, it doesn't work, then they go to laser. It doesn't work. Well, it's not because the laser doesn't work, it's the lesion has been left later. So we are advocating to use laser at really up front in multiple lesions, uncrossable, undilatable, in-stent restenosis, under expanded stent. And personally, I have used it in CTO unpenetrable proximal cap, where I tried to penetrate even with stiff wire up to a stato 40, I could not. So at this case, I took the laser catheter to the cap, activated it, and on some occasion without a wire. Of course, you have to make sure that it's in a safe position.
Yeah.
Activated without a wire with contrast, that modified the proximal cap, allowed me to put my wire through and complete the CTO. So laser really very important and very effective. There's not a single tool out of all the tools that we have is 100% successful. So if it doesn't work in some cases, it doesn't mean laser doesn't work. It's we have applied it in the wrong place. So hopefully this will be published very soon. We submitted to JAC intervention just to give a guidance to all the people who want to use laser, to put it really up front. There are cases where it has to be taken first. I said re-emphasize uncrossable, undilatable lesion. And as you know, about 70% of our cases nowadays are acute, where you don't know the anatomy.
Yeah.
You put your wire through and then you struggle. There's no wire going, no balloon going through, or the balloon goes through but doesn't expand.
Yeah.
Laser here is absolutely one of the most effective tools to be able to do it. And this is where I think this is going to be kind of positioned because it's a very effective use. Yeah.
Now, lastly, I would like to just consider two different scenarios. First of all, you mentioned about nodular calcium, and this is an area where I find is very difficult to treat. You use rotational atherectomy and you get wire bias. The burr basically moves around the nodular calcium, the irregular nodular calcium, and you don't get good debulking. Orbital atherectomy, in my opinion, basically works better because you do have this bidirectional movement and you could shave basically some of the calcium. But yet some may argue basically that even orbital atherectomy will have some wire bias and you may not achieve good debulking. Yeah. In your experience, what works better for this scenario?
Yeah, I mean, as I mentioned before, I think orbital atherectomy, we're finding that it works a little bit better in nodular and calcium. As you know, there are two kinds of nodular calcium. We won't go into that, but orbital atherectomy does work. If you are going to use rotablation, my experience or my practice, 95-98% of the time, I always use extra support wire. That allows me to the bias toward the calcium.
Okay.
And if you size correctly, i.e. 0.7 to 0.8 of the artery, you almost invariably will affect the nodule. But it's not probably as much as orbital. And of course, these are the cases where sometimes you might need to use IVL. Although IVL, again, in my clinical experience, is a hit and miss 50-50. Sometimes it works, sometimes it doesn't.
Yeah.
And I think this is because the energy probably dissipate in the normal part of the artery. But yes, orbital atherectomy is probably the preferred option, yeah. But a rotablation is still effective by using the correct size of burr.
Of course. Now, the second scenario basically is on aorto-ostial lesions. What do you think works best for such scenarios? Is orbital atherectomy still basically a winner in that case because you could go in and out?
Ostial lesion.
Yeah, aorto-ostial lesions.
Yes, I mean it's because orbital. The advantage of orbital atherectomy is you could do the excuse me, the ablation backward. So the ostial lesion, instead of affecting or causing a problem with dissection, sorry, I got. If you go and kind of do the atherectomy retrograde, that's effective.
Yeah.
But you could do the same with the rotablation. We've used rotablation for ostial lesion for many years. The orbital atherectomy is probably a little less problematic in the way because with the ostial lesion you have to be coaxial, and the rotaburr has to go really nicely through the lesion. So yes, orbital atherectomy probably would be better, but nonetheless you could still use cutting balloon, you could still use rotablation or IVL. IVL again, there's a lot of fibrosis, so it might not be the best. So if I were to put them in order, orbital atherectomy, rotablation, cutting balloon, and so on.
Okay. Professor Egrid, thank you so much for your time. That's very thoughtful discussion and very great insights that you actually gave us today. And thank you all. And we're basically keen to welcoming you back on another educational session from GIS. Thank you.
Thank you. Brilliant.